Let us start with the prayer. Om Sahana Bhavatu Sahano Bhunaktu Sahaviryam Karvavahai Tejasvinavaditamastu Ma Vidvishavahai. Om Shanti Shanti Shanti. So dear students, today now we are going to discuss about the tibial plafond fractures. Tibial plafond fractures are popularly called the Pilon fractures. Now these are severe injuries and are predominantly due to the high energy axial loading forces following the road traffic accident, or because of fall from the height, unlike the malleolar fractures, which are mainly due to the low energy rotational forces. So the pilon fractures are always the high energy forces. Now these are also called as distal tibial explosion fractures. Now you can see in this particular diagram how the distal tibia is exploded. Coming to the incidence part, here are some of the vital statistics concerning the pilon fractures. 1. It accounts for less than 10% of all the lower limb fractures. 2. Males are more commonly affected than females. 3. Mean age is 35 to 40 years of involvement. Coming to the classification, Rudy and Algover's classification. Until recently, these were the classification that was widely used. Please look at the diagram. The three types are shown there in this particular diagram. Now those three varieties which are described includes type 1, undisplaced cleavage fracture of the joint. Type 2, displaced but minimally comminuted fractures. And type 3, highly comminuted and displaced fracture as shown in this particular diagram. Now, OTA classification has come into vogue nowadays. This is the most recent classification and it consists of the following varieties. Type 1, extra-articular fractures. Type 2, partly intra-articular fractures. And type C, total intra-articular fractures. Now look carefully. Depending upon the amount of comminution, each variety is further subdivided into 3 groups. So any of these groups are again divided into 3 subgroups depending upon the fracture characteristics. Now the associated soft tissue injuries are classified into 4 categories from 0 to 3, from negligible damage to the extensive soft tissue damage. Charnay and Godgen proposed this classification. In 85% of these injuries, fibula is also fractured. Coming to the clinical features, the patient complains of pain, swelling, deformity, and inability to bear weight. Open wounds are a disaster, and the patient may complain of cold, clammy feet, and loss of sensation. Now look at the peripheral pulses and sensation in the foot without fail. There may be gross deformity and swelling of the foot. The open injuries may vary from a small wound to major gash injuries. Look for the local bruising, the fracture blisters, and if there is a tense calf muscle as well. Investigation wise, routine X-rays of the ankle consist of the AP view, lateral view, and the ankle mortise views. These are required. CT scan is more useful and gives more information about the nature and extent of the injury than mere X-rays, as it is evident from those diagrams. Coming to the treatment part. Minimally displaced fractures, type A variety, can be treated conservatively with the plaster cast. Grossly displaced fractures, they require surgical treatment consisting of open reduction and internal fixation with the plates and the screws. The external fixation is Other useful method of treatment and the methods include the hybrid fixation, the Elizarov fixation, and monolateral fixators. Now these external fixators can be used across the ankle or on the same side of the ankle. Now the primary arthrodesis, sometimes when it is considered in extremely comminuted pilon fractures where reconstruction is next to impossible, the external fixators can be used to bring about the arthrodesis. Now what is new? The hybrid external fixator is fast emerging as an effective treatment option for the pilon fractures. Here the fractures are reduced, and based on the CT study, tensioned multiple Ollie wires are placed in the epiphyseal region of the tibia. Then these are connected to the half pins located in the diaphysis as shown in this particular diagram. From proximal to distal, 3 rings are used if they are using the Elizarov, with the distal being at the level of ankle joint. And the distal ring is clamshelled or placed parallel to the ankle joint. Attach these wires to the rings using the post of various heights. This is how we treat the plafond fractures. I hope this much information is sufficient for you to write an answer in your theory examination. Thank you. Thank you for visiting my YouTube channel. Please do like it, subscribe it, and share it with all your colleagues. Thank you once again for viewing this video.